I think there have been several big advances last year. I think the first one is that the New England Journal of Medicine has come out describing the results of randomized phase 3 clinical trial comparing azacitidine and venetoclax to azacitidine alone in elderly unfit for chemotherapy patients. This was a large randomized blinded study which ran multinational, multi-site, and accrued 286 patients in the Ven-Aza arm and 145 in the Aza-only arm. So the eligibility included patients over age of 75, or if they were younger, they had to have certain comorbidities such as heart failure or angina or some others. So the results of the study were positive. Patient population was a typical elderly AML population. The median age was 76 in both groups. About a quarter were secondary AML, and about 1/3 was AML post-MDS. The response rates were comparable to the phase 1 study reported by us previously, and were in the range of 55% for poor risk category of patients with complex cytogenetics or with P50 mutations, but they reached 60 to 75%, 66 to 75% in other categories of patients. So the responses are including CR and CRI, or complete remission with incomplete count recovery. So the primary endpoint of the study was overall survival, and the study did show that Aza-Ven performed statistically better with median overall survival of 14.7 months and compared to 9.6 months with the azacitidine. Importantly, the overall survival with Aza arm was similar to what again has been previously reported for this type of population in the Aza 001 study, about 9 to 10 months. So I think this is a big step forward, and will eventually lead to the definitive FDA approval of the Aza-Ven for elderly patients who are not eligible for standard chemotherapy. From our group, we have also reported the results of the 10-day decitabine study in combination with Venetoclax. The manuscript will be in PubMed early next week. Well, actually this week. So we demonstrated high response rates overall, up to 90% newly diagnosed de novo AML. However, overall survival was fairly comparable to the 5 days azacitidine. We also reported that in some subsets of patients where we were able to add targeted therapy, such as, for example, FLT3 inhibitors in the patients who have FLT3 ITD mutation, the results were quite impressive with high response rate, which appeared to be durable, and high rate of transition towards allogeneic stem cell transplantation. In addition, I will be covering the results reported at ASH last year on our regimen of intensive chemotherapy with FLAG-IDA plus Venetoclax, led by Dr. DiNardo. So this study has 2 cohorts, one relapse refractory cohort, and then younger AML, newly diagnosed AML cohort. In the relapse refractory cohort, the overall response rates are 73%, and in the newly diagnosed, overall response rates are 93%, and the overall survival is not reached in the newly diagnosed AML, and about 9.4 months as of last December in the relapse refractory cohort. So this is, at least in relapse refractory cohort, this is at least tripling the historical overall survival, which is about 3 months in this patient population. And overall, the study appears to be safe with 0% of early mortality in the newly diagnosed patients. And again, very high rates of transitioning towards allogeneic stem cell transplantation. We also participating in the AbbVie-sponsored clinical trial with Astellas, where Venetoclax is combined with a FLT3 inhibitor called gilteritinib in the relapse refractory cohort. I will be reporting on the FLT3 mutations as a potential mechanism of resistance to Venetoclax, which can be overcome by addition of the FLT3 inhibitor. Again, the study was presented at ASH last year and will be updated this year, and they're showing a high response rate even in patients who have received prior FLT3 inhibitors. And again, many patients are able to go towards stem cell transplantation. We're still waiting the data on the durability of responses. So this is as far as clinical updates. I will also be showing some of the newly discovered mechanisms of resistance to Venetoclax and some future ways of how to overcome those with multiple clinical trials right now ongoing, what we call in triplet combinations, where the backbone is Aza-Ven, since this is now approved. And on top of that, we're adding the targeted therapies such as FLT3 IDH inhibitors, or immune therapies, for example, CD123 targeting antibody or anti-CD47 antibody. And we are looking forward for the results of the studies.